And now we go to Dr. Sandhya, who will show us the IOL trap technique for zonule weakness. Sandhya.
Thank you, Dr. Sai. This patient, when the capsular excess was initiated, the entire bag lens complex was moving, and then there was dimpling of anterior capsule when the capsule was punctured. So this indicates zonule weakness, generalized zonule weakness. And so 4 capsule hooks were used to support the capsule in the anteroposterior direction. So these capsule hooks, they've got a traumatic tip, and they will support the capsule up to the equator, unlike iris hooks. And while tightening these capsule hooks, you should not tighten it too much because it will cause denting of the capsule and also can injure the rhexis margin. And then after nucleus emulsification, see the cortex was very sticky because of the lack of counter traction by the zonules, and so it was pulled tangentially. And then after cortex removal, the capsular bag was filled with OVD. And then CTR was inserted to give equatorial support to the capsular fornix, and iris repositor was used to guide the leading and trailing eyelet into the capsular bag. Then a 3-piece IOL was injected into the anterior chamber, and both the haptics were placed over the rhexis margin just under the iris. And if you should do this carefully so that the haptics won't go under the rhexis margin. Now once the haptics are placed there, the optic was taken under the rhexis and it was captured. So once it is captured, the round rhexis becomes spindle shaped or oval shaped. So here the size of the capsular rhexis is very important. It should be around 4.5 to 5 millimeter so that you can capture the 6 millimeter optic of the IOL under the rhexis. Now then if you push this, you can better visualize the haptic optic junction, and then this IOL is very stable, it will not move, and you can better appreciate the ovalization of the capsule. And then OVD was removed from above, and you have to remove the OVD from behind the IOL also. So the basic principle here is you put a CTR to expand the capsular fornix, then place the IOL haptic on the rhexis margin so that it will counteract the downward pull by the capsular rhexis phimosis if this happens later. And the optic is inside the bag. So this will give long-term centration and stability for the IOL, and also prevent spontaneous dislocation of the IOL bag complex. So this technique, I have been using this for quite some time, and actually this will prevent the spontaneous dislocation of IOL bag complex, and the IOL is very stable also.
Nice presentation, Sandhya.
Thanks.
Yeah.
Sandhya, it's very nice. We do this optic capture regularly. For all patients, severe pseudo-exfoliation, I practice this technique. I don't put the lens in the bag. I put a multi-piece lens into the sulcus and capture it into the bag. Because they found out, David Shank's study is also there, they found out that in pseudo-exfoliation, if you have in the bag, the pseudofucodonosis is more. But if you have it in the sulcus and lock it, the pseudofucodonosis is very minimal. So that is the biggest, and late dislocation of the lens, all these you can avoid. So you put a CTR for these patients? You put a CTR?
Yes. CTR was put, sir. So yeah. I used this technique for even for localized small zonule dehiscence. So the haptics will be directed away from the area of dehiscence. So since the optic is captured, this IOL won't migrate to the dehiscence.
Now one tip I want to give, yeah, you are right, absolutely. When you are putting the trailing haptic, don't dial it into the sulcus. Sometimes when you dial it in this, especially when you have PCR, you do not know where exactly your capsular excess is. If you dial it, sometimes it may go underneath the rhexis margin, as you rightly said. So what I do is I take a McPherson forceps and drop it into the sulcus. It's called the drop down technique. So just drop it into the sulcus straight away. You exactly know where your sulcus is and drop it. Yeah.
Okay. Can I add? Thank you for showing this very, very useful, effective procedure. So after doing many, I have realized the two things. One is the sizing and the centration of the rhexis, especially in these kind of cases, to be very proper, because slightly larger you won't get the capture, slightly decentered you won't get the capture. So every case, if you practice centration and the sizing properly, then you will get very well captured IOLs. And the second thing is aspirating visco from inside the bag. So while placing the IOL, I nowadays use only sodium hyaluronate and do not inflate the bag. I inflate in the chamber on top of the iris and on top of the anterior capsule and keep the bag almost collapsed. because after placing aspiration is very difficult also, and if you do, she has shown. Well, even after CTR, whatever, we take out, I take out whatever is there even before placing the IOL from the bag. And later on also we should get it fully out. Even before capturing, you can use the irrigating instrument to take it out of the bag. Even if you don't take it out, capturing may sometimes look as though it is not captured in one side, it is tilted on one side, and later on this will not come out. It will imbibe fluid and it will bulge out, and it can cause a bag distension syndrome later.
Thank you, Dr. Sandhya. I think two major take-homes is, one is, all the new generation cataract surgeons who are not familiar with three-piece lenses. I think it's a wake-up call for all of you, because you have to be very, very familiar with inserting three-piece lenses and how to capture it. And the indications for this were initially only PC lens, because we initially thought PC lens we put sulcus and capture. But now the indications are, zonule dehiscence, pseudo exfoliation as sir showed.